Hi, I'm Sushant and welcome to this online tutorial by Quest. Polycystic kidney disease is a common cause of CKD and it presents to us in two forms, autosomal dominant and autosomal recessive. Of these, the autosomal dominant form is the predominant form seen in adults. In this tutorial, let's understand about autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease accounts for 5 to 10% of all cases of ESRD. World over, it is the fourth most common cause of CKD. As the name suggests, it is an autosomal dominantly inherited disease. That means the chance of inheritance is 50%. Also amongst these, male patients tend to have a slightly more severe phenotype of the disease. Now there are two causative genes that we have understood. First is PKD1, which codes for polycystin 1, and the other one is PKD2, which codes for polycystin 2. This second one tends to have a milder disease. That means they tend to have an ESRD which is roughly 20 years later compared to the first disease. These polycystins are protein channels and they regulate calcium signaling. They are located in the renal tubular epithelium. Polycystins are also found in the bile duct and the pancreatic duct. Patients inherit one affected and another unaffected allele. A second somatic hit to this unaffected allele leads to a variety of downstream changes. Importantly, there is an increase in cyclic AMP, leading to an increased sensitivity of the cells, especially of the collecting duct, to the action of vasopressin. This is believed to contribute to two things. One is cell proliferation and second is fluid secretion, together leading to formation of cyst. Eventually, these cysts enlarge and compress on the surrounding renal parenchyma, and that defines the polycystic kidney disease. Now, if we look at the clinical features of these patients, most patients would be asymptomatic, right up to the fourth or the fifth decade of life. In fact, good number of these patients would present before the diagnosis with another problem, that is hypertension. Hypertension is the most common manifestation of polycystic kidney disease, and a good number of them could have hypertension beginning at the age of 30. This hypertension could have variety of mechanisms, but the most likely reason is that as the cyst would compress on the surrounding glomerular apparatus, it can cause activation of renin-angiotensin-aldosterone system. This activation of RAS leads to systemic hypertension. Now, those patients who come to us with symptoms typically have abdominal discomfort. Around 60% patients can have discomfort and some of them could experience bouts of pain. This pain correlates with the rupture of cyst and can be associated with hematuria. Around 25% patients could have proteinuria. Some patients present to us with an abdominal lump, and some of them, around 30%, can present with recurrent UTI, sometimes with pyelonephritis. GFR would continue to gradually worsen over a period of 10 to 20 years, and gradually patients would slide towards ESRD. Around 20% patients could also present with renal calculi. But renal cell carcinoma is not a common complication, and therefore screening for cancers is not usually recommended for these patients. Apart from the renal complications, patients can have some extra renal manifestations, and one of the important one is intracranial aneurysms. These aneurysms could rupture, leading to subarachnoid or intracerebral hemorrhages. Patients can also have valvular abnormalities like mitral valve prolapse or aortic regurgitation. Very commonly, patients have hepatic cyst, sometimes can have colonic diverticuli, and sometimes hernia. Now, diagnosis of polycystic kidney disease rests on two things. First is a positive family history, and second, our ability to diagnose bilateral renal cyst. This can be easily done by doing a sonography of the kidney, and the number of cysts can vary according to the age, but a patient presenting after the age of 60, we need to document more than or equal to 4 cysts in each of these kidneys. MRI can be used to follow up the size of the kidney, and it can have prognostic significance. Coming to the therapy of this condition, unfortunately, we do not have any definitive therapy as of now that can halt the disease. But we can still slow down the disease by having effective hypertension control. And the drug of choice here are ACE inhibitors and ARBs. If a patient has painful cyst, we can drain that cyst percutaneously and offer sclerotherapy, and sometimes some patients would require surgical drainage of the cyst. Whenever the patient has UTI, we need to cover with antibiotics, and if the patient reaches the end stage renal disease, then either dialysis or transplant needs to be offered. To summarize, we understand now that autosomal dominant polycystic kidney disease is the most common form of polycystic kidney disease in adults and a leading cause of CKD. Two genes, PKD1 and PKD2, are responsible for this. Patients commonly present to us with hypertension, abdominal pain, and abdominal lump. And our management includes control of hypertension, treating the pyelonephritis, and taking care of painful cysts by providing drainage. When the patient develops ESRD, at that time we offer renal replacement therapy. If there are any questions regarding this tutorial, feel free to discuss with me. Thank you and Jai Hind.